All right, so we talked about coronary artery disease in the last section and how it can lead to angina pectoris and MI. So now we're going to talk in a little more detail about angina pectoris and MI. So angina is chest pain. Pectoris, like the pectoralis major muscle, it means pain in the chest. It occurs when there is a deficit of oxygen to meet myocardial needs. So there's not enough oxygen getting to the myocardium. You can get different patterns of chest pain. There's one pattern that's called classic or exertional angina. And that's what you go out to shovel snow and you get chest pain. You did it on exertion. Usually when you have exertion, the heart can adapt to its needs. It says, oh, I need more oxygen. It can cause vasodilation. You can get more blood through the coronary arteries. But when you have coronary artery disease and they're blocked, it doesn't work. And so you get that chest pain because part of the heart is being starved of oxygen. Variant angina is a different type of chest pain. It's not classic exertional. This is when it happens at rest. So it's usually caused by a vasospasm. So the vascular system is spasming and you get chest pain at rest. Unstable angina usually involves prolonged pain at rest. And it may be leading up to a myocardial infarction. So just like a TIA can eventually lead up to a CVA, angina, especially unstable angina, can precede a myocardial infarction. So it's like the arteries are getting more and more blocked, the coronary arteries are getting more and more blocked, and you're getting more and more pain, and eventually they're completely occluded and you get infarction. So usually with the unstable angina, you get recurrent, intermittent, brief episodes of substernal chest pain. And it can be triggered by physical or emotional stress. So attacks vary in severity and duration, but they become more frequent and longer as the disease progresses because, remember, those arteries are getting more and more blocked, you're getting less and less oxygen, and potentially you're going to be then getting tissue damage. Angina is often relieved by rest and administration of coronary vasodilators. So nitroglycerin is commonly used for angina. And most people who have nitroglycerin prescribed to them often wear it in a little tube around their neck. There's a little necklace that you can keep your angina medication into. So nitroglycerin primarily acts by reducing the resistance in the cardiovascular system, and it decreases the demand for oxygen. So the signs and symptoms of both angina and leading into an MI are pallor, which is paleness, diaphoresis, which is excessive sweating, nausea, and chest pain. So if someone's pale and sweaty and nauseated, that's a bad thing. And then they start having chest pain, that, call 911. Or, press that blue button if you're in the hospital. It's not a good thing. If you're working with someone, we'll talk about in a minute the emergency treatment for an angina attack. But really, it's the heart lacks the ability to balance oxygen supply and demand. So this is a diagram from the book on page 239. And with normal activity, your heart can do that balancing act of how much oxygen do I have and how much do I need, and vasoconstrict or vasodilate depending on what's needed. Well, when you have coronary artery disease, the heart can't do it anymore. It can't control those arteries to get it, so its basic needs aren't met, and you get that ischemia. So the emergency treatment for angina, stop what you're doing. So say that you have someone, you work in an outpatient clinic, you have someone work in the outpatient clinic, and they're doing whatever activity you're directing them to do, and they have chest pain. Of course, the first thing you want to do is you want to stop what they're doing, and you want them to rest. You want to keep them seated in an upright position. If the person has been prescribed nitroglycerin and they're usually wearing it around their neck or they have it with them at all times, they can self-administer, and it's usually administered sublingually under the tongue. You can monitor their vitals. You can check their pulse and respiration. If necessary, you can administer oxygen because the heart the oxygen demands of the heart are not meeting. Using external oxygen can be helpful. So hopefully your clinic has oxygen available and you could administer oxygen. For a patient who has been diagnosed as known to have angina and they know how to treat it, if the first dose doesn't make it go away, under the directions that their doctor has given them, they can take a second dose of nitroglycerin. The patient who does not have a history of angina, so they haven't been prescribed nitro, they need to go to the emergency room, or you need to call 911, depending on where you are. So if you're in a skilled nursing facility, you're going to contact nursing right away and get emergency medical aid. If you're in the hospital, you're going to contact nursing right away and get emergency medical aids. If you are in an outpatient clinic, you're going to call 911. So it's an emergency. When someone's having angina, their heart is being deprived of oxygen, and it can lead to a myocardial infarction. So let's say it does. It leads to a myocardial infarction. It occurs when the coronary artery is totally obstructed. And atherosclerosis is the most common cause of myocardial infarction. You can have a thrombus that broke off from an atheroma that's obstructing a coronary artery. Sometimes, in a very small percentage of myocardial infarctions, the obstruction is caused by vasospasm, where the artery is spasming and constricting, but most of the time it's a thrombus or atherosclerosis. The size and location of the infarct determine the damage. Just like with a CVA, the size and location of the infarct determine the damage. So in this picture, the little dark spots on the heart, that's where the artery is restricted, and that particular part of the myocardium is being deprived of oxygen, and those cells are dying. So the warning signs of heart attack. There's a big yellow box in the book on page 241 that lists these. So the signs might be intermittent initially. So I included this chart, and the reason I like this chart is because sometimes there can be different signs and symptoms between men and women. So it's important to get medical care as soon as these signs appear, because you can have permanent heart damage or death if you don't. So a feeling of pressure, heaviness, or burning in the chest, especially with increased activity, shortness of breath, sudden shortness of breath, weakness and fatigue, nausea and indigestion, anxiety and fear. You may or may not have pain, but if it's present, it's often substernal, crushing, and radiating. However, women often report a milder pain that feels more like indigestion or gastric discomfort. Women also frequently report jaw or neck pain with heart attacks. So with women, it's not always clear. It's not always the clear warning sign of a heart attack. With men, it tends to be that feeling of heaviness or pressure in the chest. Women do not always report that substernal, crushing, radiating pain. Often you get pain radiating down the left arm or to the jaw or neck. So with men, it tends to be more left arm. With women, it tends to be more jaw or neck. Also, the same symptoms with that you get with angina pectoris, pallor, diaphoresis, nausea, the marked anxiety and fear. Often people will report they have a feeling of impending doom. So one time, years ago, someone I would always be going off shift just when somebody else was coming on shift, and I would go over to the restaurant and get coffee on my way getting off shift. I don't know why I did that anyway. So the waitress who I always saw every morning, I went up to get my coffee, and she said, I had this, as I was driving in today, I had this just really feeling of fear and, like the feeling of impending doom. And right away, I'm calling 911. She goes, "What are you doing?" I said, "I'm calling 911. And the ambulance company was right next door, which is why I always went there. And they got over there in seconds and got her, got her right into the hospital and got her checked out. So warning signs of a heart attack, it's important to pay attention to these. You don't want to dismiss them because you could die. That could be the cause of sudden death. So here's the picture from the book where they show the damage caused by myocardial infarction. So you have an area of tissue necrosis from the artery that was blocked. The cells that are supplied by that area can actually die. So you get cell damage. So this is also from that same section in the book, and they show what the cells look like during myocardial infarction. So the first one, letter B, it's coagulation necrosis that they're showing, what those cells are dying. That's at a lower power, and the letter C, that's at the higher power, and you see where all those nuclei are, that's how it's supposed to look. Where there aren't any nuclei, that's where the cells are dying off. So, and that's 48 hours after an acute myocardial infarction. So diagnostically, they look for changes in the electrocardiogram. It might change the heart rhythm. They look for serum enzyme and isoenzyme levels. So typically you get those changes in the ECG that confirm the diagnosis. And they also look at the progress. They're monitoring the progress. So in the book, it lists the different serum enzyme and isoenzyme levels. You don't necessarily have to know all of the enzymes, but just know that they're testing for some of these. They're specific for heart tissue damage. Serum levels of myosin and cardiac troponin are often elevated. Leukocytosis, which is increased white blood cells, elevated C-reactive protein, and elevated erythrocyte sedimentation rate are common. So some of those tests that we've talked about before. Arterial blood gas measurements might be altered in severe cases because we're changing our oxygen level. And pulmonary artery pressure measurements can help in confirming the diagnosis as well. What they do with the pulmonary artery pressure is they're measuring how well the ventricles are functioning. So this is the little chart from the book, the changes in enzyme levels. I don't really expect you to memorize this, it's just for information, but you can see that those enzymes peak right after the heart attack, about 24 hours after, and then they start to drop off. So that's one of the ways they can tell how the heart attack is progressing, is how the enzyme levels are changing. So complications, well, sudden death, that's a pretty bad complication. Cardiogenic shock, which can cause fainting and a lot of other things. Congestive heart failure, rupture of necrotic heart tissue. So if that necrotic heart tissue ruptures, you can get a cardiac tamponade where you get blood in the pericardial sac, and it keeps the heart from beating because the heart can't expand to beat. It's compression of the heart. It's a really bad thing. Thromboembolism, which causes a cerebrovascular accident. So if you have a left ventricular MI, it can throw a clot. That's the terminology that you'll hear them use. That can throw a clot that can then go to your cerebral artery, and you can end up with both an MI and a CVA. Not a good combo. So they're treated. So I included, like I did in the electrolytes chapter, I included some of these nursing mnemonics. You do not have to remember these because we're not administering these, but it's just a little thing of interest. To know how they're treating those myocardial infarctions. So we're going to reduce cardiac demand, we're going to use oxygen therapy, Analgesics, anticoagulants, sometimes they use thrombolytic agents to keep those clots from going into your cerebral arteries. They'll use the tissue plasminogen activator. They use medication to treat dysrhythmias, hypertension, congestive heart failure, and as soon as they get that person medically stabilized, they start cardiac rehabilitation. So in your special topics class next fall, you are going to talk about cardiac rehabilitation. Interestingly enough, a lot of times in PT, particularly in acute care or acute rehab setting, we get the people that are too sick for cardiac rehab. So we have to know what to do with those people. So you will talk about that in your special topics class.